So today's topic is the IOP role in functioning, clinical clarity for effective care. Our bread and butter, stabilization, skills, level of like function, how are they functioning in their day to day, and then stepping them down. Conceptually, what is an IOP? What are we doing? We are a higher level of care than your average weekly outpatient therapy. We provide structured, multi-hour, skills-based treatment, and we're designed for people who are experiencing moderate to severe symptoms. So the acuity is higher, right? We're focused on stabilizing symptoms and improving functioning on a day-to-day basis. We're time limited and goal driven. It's not your average long-term exploratory therapy that we all love and find value in. So outpatient, that's where we do our deep relational work, longer term processing, narrative exploration around trauma, insight oriented change, and can be weekly, bi-weekly, etc., right? Depending on where a person is in their journey. IOP is stabilization, symptom reduction, skill acquisition and repetition, containment and resourcing, focused on behavioral and functional improvement. And it's that 9 to 15 hours a week. And I have to move the little bar down here because all right. IOP intensifies support to accelerate stabilization. It doesn't replace or compete with the outpatient therapy. Let me know if I'm going too fast. So, like I said, just reiterating, we stabilize, we teach skills, improve function, and step them back down. Whereas outpatient, you're processing, you're integrating into your day-to-day life for that longer term change. So what should we be prioritizing? Symptom stabilization. So you're thinking about sleep, appetite, leaving the house, completing your normal day-to-day activities, social connection, giving them skills and education in a way that is repetitive so that they're learning and they're doing it every day. We started to see people last week recognize some of the DBT work that Shannon's been doing, where they're recognizing logical mind, emotional mind, the wise mind. So giving people things that they can use in their day-to-day life that can help them with what they're experiencing, so we can see that functional improvement. Some people are going to be experiencing maybe some intense emotions and could lead to suicidal ideation or self-harm, things like that. So we're going to really want to monitor risk closely if that's present. And then, of course, care coordination, because we'd like to get this person back out to their, whether their baseline or just a new normal, depending on what they're experiencing, right? So care coordination is important because we want to start discharge planning on day one and make sure that we're helping this person get what they need and then moving them back into the world. Everything goes back to, is this person functioning? How is their functioning? So you're going to want to think about, are symptoms interfering with their safety or their functioning? So we're monitoring suicidal ideation and urges to self-harm, how often they might be experiencing panic attacks or anxiety attacks, things like that. Their sleep, we hear that a lot, that people's sleep is impacted. Appetite changes, emotional volatility, mood swings, things like that. And then if we have a person who might be in recovery and something else is going on and they're at risk to resume their use, we kind of want to look at that as well. Or like I said before too, it might not be substances, but could be other mental health concerns that might be under control, but they are at risk for increasing symptoms in that area. And then their ADL impairment, of course. IOP reduces the intensity and the frequency of the destabilizing symptoms. So the heart of IOP should feel like a skills lab, a practice container, a behavioral change environment. That's why you'll see in a lot of the groups, even if we don't get to the stuff that's in the content, like you'll see chances to practice the skills or chances to reframe thoughts or practice creative expression, because we want them to practice while they're in the program and get this experience in the program in a safe container so they can process what they're experiencing. We're hearing a lot of people respond positively to process groups, and a lot of heavy stuff comes up during shame and resilience, right? So we're giving people the education on how to regulate their nervous system, skills on how to balance both the emotional and the logical and finding a middle path, right? Reframing and restructuring thoughts and limiting beliefs, behavioral activation, exposure when appropriate, interpersonal effectiveness. A key thing that we can ask people when we're meeting with them is, how did you practice this skill since last session? And I'm already hearing from some people that they're doing body scans or meditations outside of our IOP. So they are practicing what we're giving them. So, functional improvement from an insurance lens, medical necessity hinges on functioning. So, we're going to be asking, on a weekly basis, while applicable, right? Are they attending work, school, et cetera, or are they not, right? Like, and that's why they're here. They want to get back to work or they want to get back to school. They want to get back to normal or find a different level of functioning than right now, where they might not be doing too well. So completing ADLs, leaving the house. Is their sleep and appetite improving at all? Are they engaging more socially? We're already seeing too, like group members want to connect. They know that it's like frowned upon, or we have it in our rules that they maybe shouldn't do that until after the program, right? But we're already seeing that people are getting kind of the urge or the desire to connect with one another, which I think is showing progress. IOP tracks function, not just feelings. Insurance will want to know why the level of care is appropriate, and we will need to justify that by thoroughly documenting their symptoms and ability to function. So even if you're like, wow, they're showing a lot of progress, you might want to highlight the areas of need still, right? So it's like, oh, they have good attendance. They're in every single group, but also they're still not leaving the house and they're still struggling with their sleep, right? And they're still crying all the time. So think 6 functional domains that you'll want to be looking at on a weekly basis: hygiene and self-care, sleep, nutrition, work or school if that's applicable, household responsibilities, social engagement, and of course, always safety, right? Safety should probably be at the top, but I think you all know that. And then I just have some sample questions. I can always send this PowerPoint out later, but basically different questions around different areas. So these are hygiene questions. And then you might ask them, like, what is your hygiene looking like this week? Have there been days that you stayed in bed most of the day? We hear that from some people. On a scale of 1 to 10, how difficult is it for you to take care of yourself on a day-to-day basis? Is this better, worse, or the same as last week? And then some sample sleep and nutrition questions. So you might want to know, like, what time are you going to bed? What time are you waking up? How many hours a night are you getting? Is your sleep impacting your next day functioning? And then, and in some of our groups will have sleep hygiene, sleep education, things like that. Same thing with nutrition. How many meals are you eating a day? Any restriction or emotional eating, appetite changes. And you're going to connect those symptoms to their their overall functioning. Same thing for the work in school, if that's applicable. Are they missing work? Are they having trouble getting to work? Are they getting in trouble at work because of their attendance or their concentration, etc., right? Or are they not working or attending at all due to the severity of their symptoms? So insurance loves measurable data. They missed 3 days this week due to their depressive symptoms, right? But they show up every day in groups. So that's why they still need to be here. Household and social functioning questions. You might hear people say like, I can't get to the grocery store. I can't do the dishes. I'm struggling to keep track of my finances, right? Or they're canceling their plans, or they're not connecting with people. We hear that too. Like they'll watch the phone ring, or they don't want to connect with people because it's a reminder of whatever's going on. And we can ask, is this different from your day-to-day life? What is different now? What was different then? And then risk and prevention assessment questions. These aren't questions per se, because I think we all know how to assess risk, but I have another training on for another day on that. But we should be assessing risk regularly. If a safety plan is needed, we should be reviewing those frequently, identifying their triggers, when applicable, planning for evenings and weekends if people have higher acuity. And if safety is a very, like, if safety is a concern at that time, coordinating a higher level of care if it's needed. IOP is appropriate when risk is elevated but manageable. So overall, what a one-to-one IOP session could look like: checking in on symptoms, assessing for risk if it's indicated, and even if it's not sometimes, right? You just might want to occasionally be gauging that. A review of skills that you've been practicing, troubleshooting any barriers. And that could look like something like, oh, I'm nearing the end of a program and I still don't know if I'm going to be able to find a therapist. So anticipating for those barriers that may come after they leave the program, and finding ways to make sure they're connected to resources before we get there. Behavioral planning. I love to ask people at the end of the session, what are you doing with the rest of your day? Do you have anything that you're looking forward to? And then any updates on coordination of care. It might not necessarily be 50 minutes of open processing or deep trauma narrative work. Some of that stuff may naturally just come up, right, as you're asking about these questions. That's how it's a little different from your traditional individual sessions. So if they have an outside therapist, we are building safe place imagery, the window of tolerance, regulation skills, and emotional containment. We can tell our patients that IOP builds nervous system capacity so that their outpatient therapy work can go deeper. From a utilization review lens, insurance wants to see why outpatient is insufficient, week-to-week improvement, measurable symptom reduction, active engagement, and step-down planning. We have to document the frequency and the intensity changes, their use of skills, and any gains in their functioning, and the risk level shifts. Now, how do we know that they're ready to be done, right? So if there's somebody who experiences high crisis behaviors, you might see that reduce. A more stable mood over time. They might talk about using their skills consistently. Their ADLs are improving, and they might find that they're never using their safety plan. And they're finding that you might hear people say like, oh, I felt like I really didn't need to come. Or they're starting to have less to talk about, and they're managing more, and they can kind of get what they need from just outpatient therapy, and they're not needing more support. So common pitfalls for new IOP clinicians is trying to do it all, competing with the outpatient therapist, trauma processing before people are really ready to do that, right? Like we still have to kind of build rapport. They don't know us. Not tracking the functioning, so not really being able to show or demonstrate the improvement that is probably happening, right? Not like weak measurable goals. So you might want to be a little specific in your treatment plans, right? Like you might want to say that you see their GAD-7 or their PHQ-9 decrease by 5 points by the third or fourth week, right? You want to make sure that your goals and your treatment plan have those measurable objectives. And then underestimating the importance of the documentation, right? Everything that we're doing has to be documented so that we can demonstrate to insurance this person's here, they're showing up, they're doing the work, and showing how that's reflected, which will tell insurance this is why this person needs to be here, this is why they need more time, or this is why they're ready to go. In IOP, if we can't point to functional impairment, we don't have medical necessity. So every session should connect symptoms, skills, function, and measurable change.